Hello, this is Olivia Olson, and you are listening to The Bigger Picture, a podcast where we interview scholars about how their research can make our communities better and more democratic. Today, we're going to look into the case for Medicare coverage of home safety renovations for seniors to minimize injurious falls. With me today are Richard Green, Anthony Orlando, and Patricia Harris. Welcome and thank you so much for joining us. Could I have you introduce yourselves, starting with you, Richard?
Hi, I'm Richard Green, and I am director of the USC Lusk Center for Real Estate and a professor in the Price School of Public Policy, Marshall School of Business, and Department of Economics at USC.
Thank you for being here with us today. Patricia?
Hi, I'm Patricia Harris. I am a geriatrician at UCLA. I run a medical home visit program, and that's what I do.
Well, it's wonderful to meet you. And finally, Anthony?
I'm an assistant professor of finance, real estate, and law at Cal Poly Pomona, but more important for the Bedrosian Center, I got my PhD in public policy and management from the Price School at USC.
Wonderful. Well, I'm so glad that you are all able to join us today. And I would love if you could tell our listeners right off the bat just a little bit about your research.
Richard, you want to start it off? It kind of started with a conversation between the two of us, so I think you know the inspiration the best.
So the inspiration was actually a paper that was written by a couple of guys named Gary Engelhardt and Mike Erickson 5 or 6 years ago that looked at the impact of falls on the frail elderly, and in particular, the impact of grab bars on the prevention of falls. And by grab bars, I mean much specifically in bathrooms. So grab bars to allow people to get out of showers and to get off the toilet with some support. And what they found is you had substantial falls reduction when you installed these grab bars. And they had a very clever strategy for determining that it was the grab bars, not that people were more cautious people would put in grab bars, which is if one spouse fell and as a result of that had grab bars installed, if you observed the falling pattern of the other spouse, you would see that they would fall much less often than those in a control group whose spouses did not fall and who didn't have the grab bars. And what they found, long story short, is the cost of installing grab bars pays for itself in less than a year. Because of falls prevention, and at the same time, because falls are expensive to the healthcare system. When people break something, obviously, that's going to cost a lot of money because you're getting into orthopods when you do that. And so there was a possibility of a policy that both saved taxpayers money and led to happier and more dignified aging. That seems like a no-brainer. Okay. About the time I was reading this paper, I was also in the Obama administration as a senior advisor to the Department of Housing and Urban Development. And I said at HUD, we should just install this stuff. And they said, yeah, but that doesn't score well from a budget standpoint because we would spend all the money and HHS would get all the benefit. And so I went to HHS and I said to them, well, this should be a Medicare benefit. But it proved difficult from both an administrative and legislative standpoint to actually implement this. And so that's sort of my point of departure. And then I'll talk to Anthony about how he picked it up from there.
Yeah, I'd been doing some research for a couple of years with our mutual friend and colleague, Raphael Bostic, on social determinants of health and how so much of our healthcare expenditures can be linked back not just to the medical system, but to things out in the world, everything from the neighborhood you grow up in with the type of environment that you live in and the air that you breathe to the type of the housing quality that you have, which includes whether it's been renovated to have these home safety kind of features. So one of the challenges that Raphael and I faced, we did a report for the National Academies of Science, was it's challenging to pay for these things for exactly the reason that Richard is talking about, which is you're crossing over boundaries between silos. So much of social determinants of health requires fixing something that doesn't seem like a healthcare problem, but will result in a healthcare benefit to society. And so when Richard and I started talking about it, it seemed like a natural thing that we should propose that Medicare should be more interested in addressing these kinds of social determinants of health. And then I'll pass it over to Dr. Harris because we realized that neither of us has any expertise in gerontology or expertise in older Americans' healthcare. And so we really needed somebody to make sure that we weren't crazy.
So I was very happy to provide the boots on the ground expertise, including risk factors for falls, interventions that have been shown to reduce falls, and just give a general background as to how one could implement a policy like this and make it workable. So I kind of was the background person and the out of ivory tower person as well. And I think it's a great idea. And you're absolutely right. This is a social determinant of health. It is also a problem that people don't recognize as a problem unless it's brought up to them. And a policy that would put a grab bar in place before a person actually fell could only be a benefit. And I think that our paper shows that.
Wonderful. So one of the things that was both mentioned in the article and that you all touched on to some extent was the issue of generating political will and actually implementing this policy. How do you see overcoming the barrier of generating political will, and what do you hope to have happen as an outcome?
Well, I'd be curious for Richard to say a little bit more about his experience in the Obama administration and what he sees as because he knows some of the people who are in the Biden administration now. But I will say that I think we're more optimistic that these types of ideas will be taken seriously over the next 4 years than they might have been over the previous 4 years. And I do think that, at least in the spheres that we work in public policy, there is a growing understanding of the fact that so many issues are interdisciplinary and that they require interdisciplinary solutions. And places like USC and UCLA are starting to invest more and more in that. So hopefully there's a growing awareness that pushes for it. But I can't speak to the inside politics as well as Richard can.
So, well, to some extent, Patricia helped me with the inside politics because she was a health policy fellow at the Department of Health and Human Services some years ago. And while she was there, one of her colleagues as a fellow became a senior official at CME, who are the people who determine how Medicare and Medicaid spending is done. Or is it both Medicare? I guess just Medicare, not Medicare, Medicaid. Anyway,
Well, it could be both.
It could be both.
Yes.
Okay, that's where, Dr. Harris knows a whole lot more than I do. But anyway, I brought this idea to this official, and she was very enthusiastic about it. And on the grounds that, for starters, I was the rare person who was bringing an idea about something that should be covered where I had no financial interest in it being covered. Is usually for if somebody wants equipment covered under Medicare, the person wanting that equipment to be covered is the manufacturer or inventor of that equipment. And they have a financial stake in it. And so she said that the nice thing about me bringing this to their attention was that I was pristine. In general, I'm not a pristine person at all. But in this particular matter, I was pristine. I had no financial interest in making sure this happened. And so she was very enthusiastic about it. She saw the idea right away. But as she explained it to me, there had been legislation many years ago that defined grab bars as what are called convenience devices instead of medical equipment devices. And as a result of that, you needed to go through a process for a patient to be able to get access to this and have it be covered. So it can be covered, but it's almost like this is the problem. It's an after the fact kind of thing.
Interesting.
Right? You have to show demonstrated need, which often means people have fallen already. Well, the whole point is you want to install it before it's fallen. And in order for this to, in order for there to be a change, there would have to be legislation that would allow for CME to designate this a medical device, which could mean that they use it as a preventative as opposed to a curative intervention. Well, when I was in the Obama administration, as you may remember, Republicans held both seats of Congress, both sides of Congress. And, I will be bipartisan here, although I really hate to be bipartisan. Nobody was interested in making anybody look good in Washington. at that time. And so I talked with some of the usual lobbying groups. They showed some interest in it. I think people can figure out who I'm talking about, but I don't want to throw them under the bus as being ineffective, because I think they tried. But just getting anything through Congress and onto the president's desk during that period was very difficult. And now I think the key thing politically is, now that we have a president and Congress from the same party, perhaps if this is adequately raised people's attention, there might be an opportunity in the next 2 years to do something with this.
Wow, that is wonderful news.
Well, no. I said perhaps. I mean, I just threw a bunch of caveats out there, and
I'm still taking that as a positive. And here we are doing an interview and raising some more attention and interest in this topic. So I can only help, right? Well, you mentioned your own pristine financial interest background, but on the subject of
in this one particular.
In this one particular, we'll get into that a different time. But could you talk a little bit about the financial feasibility of this getting off the ground and being financed by Medicare?
I can give a couple numbers to get the conversation started. So Richard mentioned that in the paper by Mike Erickson and Gary Engelhardt that they had done an initial benefit cost analysis, and they essentially showed that in only a year or two afterwards, the benefits were over 90% of the cost. And inching towards 100%. And then what we did was try to update those numbers, because the healthcare costs, since they had done their study, had grown a lot faster than inflation. So the medical savings that you could get was actually now much higher than the costs. We found that it was somewhere closer to over 20%. So $1.20 saved in the long run relative to the costs.
Excuse me, Anthony, it wasn't really long run. I mean, a year is not.
No, sorry, you're right. Over 2 years, not the long run at all. So that's another point that we made in the paper, is that actually Mike and his co-authors did a very conservative estimate, because they're only looking over 2 years. They're not looking at fatal falls, which can be a lot more expensive. And they're not looking at non-medical savings. So Richard mentioned, the stresses that come with a fall, the stress is not only on the person who's affected, but also on the caregivers, which I think Dr. Harris can speak more specifically about what that's like from the perspective of seeing the families go through all of this. So the benefit cost was one thing that we tried to emphasize. And speaking as what we can do politically, to your other question, I think it's relevant to say, as scholars, there's only so much we can do, but at least we can try to give the evidence that people can use to make the argument. And so the other calculations that we did that we thought would be helpful is to show how much cost are we really talking about to Medicare. You can imagine a politician saying, well, maybe it'll pan out in the long run, but right now I don't want to spend that much money. And we said, okay, let's look at 3 different scenarios. A very small scenario where you do a pilot program with 100,000 beneficiaries. A middle scenario where you do any new enrollees each year, which is about 1.7 million enrollees every year. Or a scenario where you try to cover everybody, no matter how long they've been on Medicare. And in the smallest scenario, which is not small, 100,000 people would be a great benefit for society. You're talking about less than 0.1% of the Medicare budget. It's a very small amount. These are very cost-effective things to do. It's not expensive to make these renovations, especially relative to the size of how much Medicare spends. And even in the situation where everyone could possibly get it, and we were making very conservative assumptions about all of this, you're talking about less than 2% of the Medicare budget. So those are kind of the ballpark numbers that we came up with, and we hoped would be helpful to policymakers trying to make this pitch.
Patricia, do you have anything to add?
No, I think he made his case very succinctly. The only thing I could add is sometimes in population health, we look at the number needed to treat. So how many people would require, how many grab bars would be required before you actually prevented one injurious fall? And we don't have the exact numbers, but just knowing, not in this paper, but in other papers, a intervention like this, the number needed to treat is quite low, like 5 people would need to be treated, so to speak, with a grab bar before you prevented one fall. In cancer, number needed to treat is sometimes up to 100 to get one benefit. So you're looking at a very cost-effective way of keeping people healthier.
And Anthony, to go back to your earlier point about a limited role as scholars in implementing change, what do you think that people such as our listeners can do to help promote this as change that needs to happen?
Well, that's a question I wrestle with a lot. I think we all feel like we wish we had more influence for those of us who are, invested in caring about these issues and about our society. Part of it is just making sure that you vote, and making sure that you vote for leaders who you think take these issues seriously, who both have the intellectual capacity that they really think about these issues, and that they actually care about these issues. I think I'm not going to, again, following Richard's lead, I'll keep it bipartisan. I'm not going to recommend any particular politicians, but I think it's clear that some experts think more about these things and care more about these things than others. I'd be curious to hear what Richard and Patty have to say, because, we, in our personal roles as professors, as a doctor, we interact with people on a daily basis where we can educate them a little bit more about these types of issues. And I think we all hope that people will then take what they've learned and then talk about it with other people in their community. One challenge we have with the social determinants of health is that some communities are just much better educated about these issues than others. And even spreading the word about how important this issue is might inspire some families to make the renovations on their own if they can afford to do it. And that would be a plus too, if it's within their financial means.
Yeah, I would agree with that completely. The big picture, obviously, is making it a Medicare benefit, but from a smaller scale, we could consider education on the more local level, including senior centers once they're up and running again, or even considering a alternative payment system in Medicare, for example, Medicare Advantage, which is an HMO scheme for payment. They have much less stringent requirements on their capitated fees. And so they may actually consider putting in grab bars for their insurees without going through Medicare, because they're allowed to do that kind of thing. So if we are thinking more broadly, we should start thinking more locally.
Could you explain capitation briefly?
Oh, excuse me. Capitation is a system where an insurer will pay, or in this case, Medicare will pay the insurer a top rate to cover a patient for all of their medical needs, regardless of how much that person actually costs. So the idea is to pool resources among everybody in that HMO, every patient, and spend them according to need rather than simple costs. Therefore, they have many more, they have much more leeway to do what they want with the money, including population health and public health kind of measures like grab bars, whereas Medicare would be much more stringent.
Yeah, so it's you just gave me an idea I didn't have before, is we should be pitching this to HMOs.
Yeah, we should be. Absolutely.
So Patricia, what you just mentioned that really resonated with me was not just thinking interdisciplinarily, but also thinking locally. So in the title of your study is Breaking Down Silos to Improve the Health of Older Adults. Can you tell us a little bit about what it means to break down silos and why it is important to do so?
Sure. Well, the silo we were considering is the cost savings for Medicare would actually be, so it would cost somebody, say, in housing, like in HUD, to put in grab bars if they're, say, building subsidized housing. So the grab bar, the cost would go to HUD, but the benefit would go to Medicare. And so that's actually a financial silo that you can't overcome in government. It doesn't really care if Medicare saves money. and Medicare is really not interested in getting into the home building business. And so that silo there would actually have to be some work among legislators to overcome that kind of financial silo so that we could actually implement change at the federal level. There are other silos, like the fact that working with Richard and Tony meant that I had to look at statistics, which I know how to do, except our terminology is completely different. So we could be running exactly the same calculations, but my terminology was so different from theirs, I had absolutely no idea what they were telling me, and vice versa. And we've actually had to overcome some of that among the three of us.
Well, and the other thing is, from a standard of care standpoint, is physicians tend to think too much in terms of silos sometimes. They are heart people and they don't think about the remainder of the body. And again, this is not a criticism. It's really, really hard to be an expert on the heart. It takes all of your intellectual power in order to be an expert on the heart, but nevertheless, you become so focused on the heart that then you forget about maybe other parts of the body. And similarly, physicians can look at patients as just people who show up in their offices or at the hospital, whereas medicine, see, I'm queuing you up, Patty, on this. Understanding the context in which people live is important to practicing good medicine, right?
Yes. The average cardiologist or cardiothoracic surgeon is sometimes unaware of the social determinants of health that we have been talking about today. That cardiologist may say, wow, if you fall again, you're going to have another heart attack, but then has absolutely no idea how to implement change that would reduce the risk of falls. So there are silos within medicine as well.
Yeah, I always love the story. Michael Marmot, who's one of the pioneers in social determinants of health, who's a British epidemiologist, talked about years ago, before anybody was talking about this, he's in the hospital, they're treating a patient who had a heart attack, and they treated the man, and then they sent him home, and he realized, I'm sending this person right back to the exact circumstances that caused the heart attack. He's not going to change anything about his behaviors. He's not going to change anything about his environment. And so what good am I really doing? I saved him today, but shouldn't I be also thinking about saving him tomorrow and the next day and preventing down the line? And so, part of the silo is just what's happening inside your office, which happens to all of us, and trying to understand how the role that we're playing connects to the role that other people are playing. I mean, one of the things that was fun for me about this project was working with Dr. Harris. That's not a silo that we usually break down. I learned a lot just from that collaboration, see it from her point of view.
Very interesting. Do you have anything else that you would like to make sure that we touch on before we wrap up for today?
I guess I'd like to ask Patty one more question that occurred to me as we were having this conversation. And if this is awkward, I'm sure you have people, Jonathan can edit or something like that. On the political stuff, since you're involved with organizations that advocate for healthcare and particularly general internal medicine and geriatrics and so on, do you think this would be a priority for any of the groups that you're involved with, or are they so caught up in other issues that they would not make this a legislative priority?
That is a very good question. I think that we have all been beaten down by the last year and are just now kind of coming back up and trying to figure out what our priorities are. My guess is not this year. There's enough to do this year, but perhaps in a year or two, it might be an issue that they would address. The other thing is sometimes all you need is a legislative advocate. So, for example, if we could find a member of the appropriate committee whose parents both fell and broke a hip recently, they'd get all on top of the grab bar and rush it through. So maybe we should read the gossip columns more often.
Does it need to be both parents, or would one parent be good enough, do you think?
Well, that's a good question.
Or would pushing also work?
But seriously, advocacy is all personal, right? You find the personal angle, and perhaps we could take this further. But without that personal angle, it's going to be lower on the priority list right now. Yeah.
I think, you mentioned the difficulties of the past year weighing on this. In some ways, I think that could be an inspiration, because if one thing that has become pretty clear to all of us in the last year is the importance of feeling safe in your own home, and the importance of, especially for older adults, feeling like they have a safe place to age in place, so that they won't be institutionalized prematurely. And they during a time like a pandemic, it's becoming increasingly obvious how important that is to our society, to allow people to have that option if they can. And so that might just add an extra reason for people to care about this.
True.
Absolutely. Well, thank you so much for your time and for writing this really brilliant paper. I encourage all of our listeners to read the whole paper, which will be linked with the summary on the Bedrosian Center website.
Folks, it's not very long either. So
it is not very long. I think it is the most accessible academic paper I've ever read. It is succinct, it is clear, and it is a really important issue. So thank you all. And I am honored to have had the opportunity to talk to you today. Thank you for listening to The Bigger Picture. For links of some of the things we talked about today, visit our show page, bedrosian.usc.edu/bigpicture. And if you have more questions for our speakers or topics you'd like to cover, let us know. Check out our website, social media, or even email us. Subscribe on your favorite podcast app and leave a review so other people can find us. Until we catch up again, we hope that you will take care of yourself and your neighbors from all of us at the USC Bedrosian Center. Thank you.